It's my pleasure to introduce our next speaker, Judy Dollins from the American Academy of Pediatrics. For those of you who may not be familiar with the AAP, the American Academy of Pediatrics is a professional organization of 67,000 pediatricians from all across the world, including myself, that is committed to the optimal physical, mental, and social health and well-being of all infants, children, adolescents, and young adults. Judy is the Chief Implementation Officer and Senior Vice President of Chapter and Community Affairs and Quality Improvement for the AAP. In that role, she develops strategies and directs programs and initiatives that improve the health and well-being of all children under the umbrella of the mission, vision, and goals of the AAP. What Judy will be talking about today, it's a pretty exciting and innovative project by the AAP on a clinical data registry that has multiple goals. Key goals are to develop quality metrics for value-based payment and also data that can be used for research and benchmarking.
Good afternoon, everyone. It's such an honor and pleasure to be here. I'm really grateful that I've just heard such wonderful talks and met so many wonderful people in just the day that we've been here. I think I'm learning more than I'm going to be able to share with you, so thank you. I'd like to share with you where the AAP is on our journey to build a clinical data registry to improve children's health care for all U.S. children. That's 74 million children. And what we're doing is we're in the middle of our planning work, and I want to just tell you about where we're going and what that's going to look like. You know, I just realized I don't have a clicker. It's on the couch. Got it. Okay. Okay. So to sort of set the context for this project, these are trends in healthcare that you all know about, but I want to tell you a little bit more about why they're important. The move to value-based care, moving from volume to value, was really initiated by the federal government, and it was initiated with alternative payment models for Medicare patients. So, except for the nephrologist, nobody else in this room actually participates in Medicare, but as Medicare has always driven new technology and the way that healthcare works. Most recently, through the MACRA legislation and the MIPS program, now if you are, you have to be submitting data, quality data, and if you don't, you can lose up to 9% of Medicare payment. So this is important. And what does that have to do with pediatrics? Well, private payers are also looking at value-based payment, as well as some state Medicaid programs. And CMS announced last fall that in 2024, all states would have to submit data on the 26 measures in the CHIPRA core set for children. So we don't know what that exactly means yet. They made that announcement. They haven't said anything else about it. But we suspect it will have something to do with moving more and more towards value-based payment in Medicaid. The second trend is the growing prevalence of data. So of course you all know that. EHRs are just about ubiquitous now. Data is available for quality assessment, for research, for improvement. And healthcare knowledge is moving so quickly. It's every 73 days, we double the amount of knowledge. There are 800,000 articles produced every year. So who can keep track of all this? How do you keep up with all the data? So that's the prevalence of data is certainly something that we need to help clinicians with. And then finally, the improvements in technology integration. So the federal government also, through the Office of the ONC, had mandated a greater use of exchange of data between EHRs. So it's gotten easier, certainly with the FHIR standards, to be able to do this as well. But what if, what if all that data that's available could be harnessed in ways to improve children's health care and children's health? What if there was sufficient data to predict the trajectory of an infant born exposed to opioids? There's a lot of children now who are born exposed to opioids. I was just talking with somebody earlier today about could there be technology used to actually monitor the child while they're still in the hospital or even when they go home. But what's the trajectory of their life? What is that going to look like? What if there was pediatric quality measures across all payers and they were all harmonized? So if you were taking care of children with asthma or with ADHD, for value-based payment, what if you used all the same measures instead of for each payer you had a different variant of a measure? What if there was data to know how clinical guidelines, the Academy produces a lot of clinical guidelines, and you all have in hospitals have your clinical pathways. What if we had enough data to know that they were all implemented and if they were effective? That would be good information to have. And finally, what if the incidence and treatment data could be quickly captured to inform a public health emergency? Think about Zika, what happened with Zika. There was no one collecting the data in a registry for Zika. But what if you could do that pretty easily and it could inform what to do in a public health emergency? So the AAP's innovation is to build a registry to collect, store, and analyze data for every child in the United States on their health, on diseases, both acute and chronic, on their wellness, their behavior, and development. This is a big deal. This is a lot of work. And so we got to figure out how are we going to get this done. So the first question I asked, and by the way, my boss came to me and said, "You're going to do this." And I said, "Oh, okay. Why would we build a registry now?" So in data that we collect, we do periodic surveys of all of our members. We have 67,000 members in the United States. 94% of pediatricians now use EHRs. It's pretty good. And actually, that was 3 years ago. It's probably even higher now. There's an unprecedented amount of child health data is available electronically, and most of that data is coded. So the data is out there. It's just a matter of capturing it and then using it. Also, the pediatric certification of EHRs, or pediatric EHRs, is pending. The Office of the National Coordinator has already put out what the functionalities have to be. I don't know if you pay attention to these things, but that's out there. And next coming is certification of pediatric EHRs. So that will help help us to build a registry as well. And over 50% of pediatricians participate already in value-based payment, even though we don't have the same requirements as under Medicare. So all of these sort of push us in that direction as well. And yet there are many existing pediatric registries. Just show of hands here, I can't actually see you all that well, but how many of you are putting data into the registries that are up on the screen? Anybody? So I see a number of you already are. Okay, most of these are disease-specific. They're rare diseases. They are certainly research registries, and they're often episodic. They are not longitudinal data collection. The child registry could actually be a registry of registries and pull all this data together. So we believe that a child registry would improve children's health because you would have the longitudinal data to get the full experience of a child's health care and what they've been through over the course of their lives. And it would allow us to really look at the trajectory of children's health. It's also important as a membership organization, the Academy has 67,000 members, that we stay relevant to our membership. And currently, our early career physicians, they have always used EHRs, and they are used to using registry data as well. And they expect the Academy to stay relevant and provide things that they need. And one of the things that they've asked for among the hospitalists in particular, and hospitalists are the fastest growing group, it's the newest board specialty, and they're asking for benchmarking data. They want to know, how do we compare as a children's hospital to another children's hospital, or even to community hospitals? Are there regional differences? So we know that that data is already being looked at and desired by the hospitalist community. And then who better than the Academy to lead this effort? The Academy is the largest pediatric organization in the country, 67,000 members, and we're often seen as a trusted partner. We focus on producing policy, education, and advocacy, and I think we have a pretty good reputation out there. I know that not all of you are members, but I encourage you to join. So what did we do? How did we approach this project? Well, we put together a Child Health Data Registry Incubator Group. And it's led by Chris Lehman, who is kind of a leader in informatics, pediatric informatics. He's also a neonatologist. Sue Cressley actually has she and her husband have an EHR company. She's also in practice in primary care. Sandy Chung worked on the HIE project in Virginia. Michael Weiss is here at CHOC, and he is the leader of a pediatric ACO, which there were only 2 funded pediatric ACOs funded by CMS, and he is leading one of them. Suresh, who introduced me, and it's probably the reason why I'm here today, is on the board of iSpy. Kevin Dukendak is at Cincinnati Children's. He's also involved in informatics. Amy Tyler is a hospitalist from Denver. She's the one who said, we need a dashboard, and we need to know how one hospital compares to another in terms of outcome care. And Michael Chang was instrumental in building the IRIS registry in ophthalmology. So this group decided that the purpose of the child registry was to enable pediatricians and others who care for children, because pediatricians aren't the only ones who do, there's also family medicine does, to improve child health and well-being through the use of data. So that's kind of the overall plan, but it doesn't tell you much. Since we had a lot of informatics people in our group, the first thing they said is, oh, we gotta talk about data security and data privacy. So we kind of called this out and spelled it out and said that pediatricians would own their data, but ultimately patients own their data, but at least the physician has it in their records. Pediatricians would have to give permission for the data to be distributed and reported, so we'd have to have BAAs with everyone. The AAP would own the aggregated data. Data protection, security, quality, and audits would have to be in place that would be supported by HIPAA to make sure that we're HIPAA compliant. And the integrated rule-based access, so there would be levels of access as who could see what data to make sure that, again, the data would be well guarded and protected for patients. PHI would be stored separately, and our vendor partner would only have access to PHI for vendor purposes. New data would be able to be linked from the same patient, so you'd have to have a way to do that kind of linkage. And PHI would not be available on any kind of dashboard or any analytical tools. The other thing is that we would not build the registry ourselves. We would have a partner to do that. So I've named a lot of things that this registry would do, and some use cases I've kind of spelled out for you. But there's a lot there. So we did some real thinking about, so where do we start? And what's the most important thing? So what's the registry really going to do? And you might notice that this triangle sort of looks like maybe Maslow's hierarchy of needs, and that was the basis of putting this together to explain the value of investing in the child health registry. So you have to start with actually collecting some data, so it's got to be people who are willing to give you their data, and that there would be value at the very sort of lowest tier. So value for value-based payment is sort of at the very bottom because it's important, and a lot of people want that kind of data. Data for improvement and for MOC. Everyone has to do MOC. Why not make it easy for them? If they're putting in data and we have quality metrics, would be a simple way to provide the MOC for them, for pediatricians. The harmonizing of quality metrics across payers. That's something we hear about all the time from pediatricians, so let's get that done and make that sort of in the first tier. Data for the chipper quality metrics. As I explained, it's coming, and we want pediatricians to be ready, so you would be able to get this data from the registry. Data for benchmarking and for regional differences would kind of be at a second tier. Then as we gather more data, we want to be able to have patient-reported outcomes to enhance health. We think patient-reported outcomes is really important. There are numerous ways to get this done. It wouldn't happen immediately, but it would be certainly something kind of at the lower end of the pyramid. Then research to improve child health, but you have to have enough data in the database to be able to do the research, so that's at a higher level. And then finally, actually having longitudinal data for trends and improvement over time. Besides pediatricians to be able to use the data, we also know that there are some other stakeholders, and they would find value in this registry. We talked about AAP members, patients being able to engage with clinicians and report their outcomes. And we'll talk a little bit more about that in a second. Informing policy, population-based research and public health surveillance. And what programs should Medicaid invest in? What should the government invest in? We'd be able to provide data for that as well. Provider groups, the quality benchmarks and performance data. For payers, to actually design better payment methods that are based on quality and quality of care. And then for research, having research-grade data. So some of the key aspects of the registry would be automatic extraction of data from EHRs. We want to minimize the burden on pediatricians. We know that this can be done. There are companies that already do this. We've actually talked to several of those companies already. The registry has to be HIPAA compliant. There has to be patient matching. We'd like there to be a unique healthcare identifier for every child. The federal government is barred from doing this, but the Academy as a private entity could do this. Analytical tools for pediatricians would be part of the registry, as well as a platform for maintenance of certification and QI. That would be something that the Academy would have built into it so that we could help pediatricians to meet those goals. And then it would be run by a data governance board. Okay, so for the patient-reported outcomes, so PROM surveys could be put in and for patient-reported outcomes. They could be done manually, they could be done through smartphones, and it's something that is really important to get the feedback on how are your patients doing. So there's a lot of work going on to have the right use of antibiotics, and many times for acute otitis media, you're supposed to prescribe a SNAP or safety net antibiotic prescription and ask the family to not fill the prescription unless the child is not getting better after 2 or 3 days. But how do you know if they ever filled it? Because it's not so easy to get the pharmacy data. So you don't know if they filled it or not. Now, if the child doesn't get better, they may have filled it. Did they give it to the child? And that's important data to know, because what if they filled it right away? So the whole idea of doing it didn't make any sense. So I think there are some pretty regular examples of how the registry could improve the practice of medicine. Not initially, but eventually, as the registry grows and more data gets into it, we'd like to be able to get automatic collection of patient-reported data from wearables and sensors. We've talked about this at this conference, and we think that that's something that would be a good thing to have in the registry. Also, natural language processing, which we just heard an explanation of all that, to capture unstructured data from physician notes. And we wouldn't be able to do that probably immediately, but over time, those are places where we think that the registry would need to go. So the incubator group has done a lot of work. One of the first things they did was to get input from members. So at our conference last fall, we went to 5 or 6 different groups and sat down and met with them and told them what we were thinking about with the registry to hear back, does this make sense? Are there problems with this? Would you participate? And overall, the members were pretty excited about it. They did have a few things that they were really, really worried about: data security. They were also worried about the reputation of the Academy. They wanted to make sure that nothing in the registry would hurt the Academy. And we also met with the Family Partnership Network. So the Academy has a group of parents who are regularly at our board meetings, help us to write policy, and we met with them and to get their opinions. What do you think about this registry? Well, the thing they liked about it the least was the word registry, because registry means something different depending on who you are and what your life is all about. Several parents have been on Medicaid before, and they were on welfare, and they just didn't like that word at all because it looked like, what is the government taking from us? What are you doing? So we're very mindful of that. I mean, we're still calling it the Child Registry at the moment, but we have not come up with a better name yet, but it's really something that we're thinking about because we don't want families to feel like, you know, Big Brother is watching me, or, you know, what does this mean for you? What does this mean for my child? How are you using this data? So we have work to do on messaging. We've met with the registry vendors. There are about 3 to 4 vendors out there who have the right technology and enough experience to do what we're trying to do. We met with them last summer, and we're meeting with them again. And they're very willing to share what they can and can't do. We have not put out an RFP yet, but I think the discussion with each of the vendors is quite important. We have worked on a detailed requirements document, and we're currently working on putting together a minimum viable data set, and as well as a pediatric measure set. We have also conducted meetings with payers, with all of the private payers, just to get an idea of what kind of measures are they interested in, because we want this data to be able to be used by payers if physicians want to use it for value-based payment. And those have been very interesting discussions, and they certainly will inform what kind of measures we would have in the registry. So our work is also focused on benchmarking to determine pricing models, and we've looked at about 26 other registries that have been put together by medical societies. Very interesting, because almost all of them have actually made the initial investment themselves and then figured out how to monetize their data. We are just beginning to look at, you know, what does it look like? How do you price this? Who pays for it initially, and who pays for it in an ongoing way? We've also done some market testing with potential participants to see if they would even be willing to pay. Generally, our board does not want us to raise dues, and they don't really want us to charge people. There may be some initial fee, and we're working on that kind of pricing structure as well. We also developed a very detailed business plan, and part of that business plan is a sustainability plan. So what we've looked at there is we know that pharmaceutical companies and device makers are interested in pediatric rare disease data. They're not that interested in just primary care healthy children, and which wouldn't surprise anybody. So we're exploring vendor partnerships with experience in licensing data for real-world evidence, for post-market surveillance, for clinical trials for rare diseases. Where do you find those patients? And we might be able to help with that. And also for predictive clinical decision support. So there have been some very interesting discussions, but you do have to figure out a way to keep the registry running and keep it going, because there are costs to doing it. We have also decided, though, that any kind of partnership that we would have with the vendor would be subject to AAP governing principles. That means that we make the final decision of who we're going to license data to. We have to know exactly what the purpose is for the data, because the Academy has always wanted to keep its reputation. And we don't want to be looking like we're selling out to other industries. So in conclusion, this is really all about helping every child to achieve their full potential through access to high-quality care that is based on research, evidence-based guidelines, and effective benchmarks. And I'd be happy to answer any questions. Thank you. Yes. Yeah.
Mark Clements, Children's Mercy, Kansas City. So thanks, that was really insightful. You know, I participate in National Pediatric Type 1 Diabetes Quality Improvement Registry that is growing, and you mentioned a number of other registries. So I'm wondering how, number one, you implement this without sort of replicating the work of all these individual disease registries, you know, perhaps how you partner with them rather than run in parallel to them. The other question I have is I like the approach that you're taking, you know, to get longitudinal data through a vendor partner from the electronic health records. It's exactly the strategy that we're taking that I haven't seen other pediatric quality registries really take. Most of them, as you mentioned, are very intermittent in their data collection. And then finally, I wonder whether you're familiar with the CDISC effort to standardize data collection to support real-world evidence in clinical trials across the world.
So let me start with the first one. So we have not had discussions yet with other registries, and partially because, you know, we still haven't built one, but that would be part of sort of the next bucket of work to see who would be willing to partner with us. We've been asked the question every time we talk about this is, so are you going to get all the data from every state's immunization registry? And the answer is probably no to that, because how many of you work with your state immunization registries? Anybody doing that? So those are not easy, right? They're not easy, and I know personally I think federal government made a big mistake when they said every state go do it on your own, and none of them can talk to each other, and you know that sort of means that no child should ever move from one state to another. I think that we want to look at what all those other registries are and whether they're willing to partner with us. I mean, the difference, though, of being able to collect data longitudinally, and they're not necessarily always collecting it longitudinally. So I think there'd have to be a discussion probably with each one. Plus the fact that they're using probably different technology than we would be using, because technology is changing so rapidly. So I don't have a perfect answer for you yet, but it's certainly something that we've been thinking about how that would come together. Then your second question was not really a question, it was just more, yeah. So no, I'm not familiar, but I'd be happy to learn more about it. And if you'd like to share that with me, I'd love it.
Any other questions for Judy? If I can add one comment to that question, Judy, being part of the incubator group, looking at other registries which are primarily disease-based, and they do serve a purpose. When you look at diabetes or CF or asthma, some of these are local, some of these are regional and national registries, which definitely add value. The AAP's child registry focusing more on health and wellness and across a longer time frame. So there may be a difference, sort of a high-level difference with the AAP child registry compared to the other disease-based registries. So, any more questions? No? Thank you. Thanks, Judy.
Thank you.